Yeah. Yeah.
Shall we begin?
Yes.
Good evening. And if you are in a different time zone, good afternoon and good morning. I'm Dr. Juya Wang. I would like to welcome you to attend the APAACI Masterclass webinar. As this webinar have been already started for during the pandemic era, and we think this is very quite important for our young allergies. And also, I would like to thank the excellent speaker to attend this webinar. And tonight, we were going to addressing the important challenge for food allergy and allergic rhinitis. And I will introduce you to our immediate past president and also our executive director, Professor Rupi Pawankar, to make a short introduction. But all in all, I would like to welcome you and then hope you can enjoy tonight this masterclass seminar. Professor Rupi Pawankar, please.
Thank you, Professor Wang. It's my pleasure to actually welcome all of you as I join Professor Wang in welcome you all for good morning, good afternoon, good evening. As he rightly said, this series of masterclass and webinars have been there now for several years, all through the COVID, on very, very important issues. And today is a very, very important topic. And without fail, I would like to ask you all to make sure you attend it. If you're coming a little late, also join us, because don't miss this wonderful opportunity. And before I go on to introducing our moderator, I would like to remind you and invite you to the APAACI 2023 in Singapore from the 23rd to the 26th of October. And this is going to be an outstanding conference with fantastic scientific topics and a beautiful city you should never miss. So we're all waiting to welcome you there. And now I would like to introduce Professor Romel Lobo, the moderator of this session. Professor Romel Lobo was the president of APAACI when we organized the joint meeting last year in Manila in December 5 to 8, which was a great success, an outstanding success with an outstanding scientific program led by Professor Recto and also her team and our team too. Professor Lobo is a board member of APAACI. We're proud to have him as our board member. He is also the immediate past president of the Philippine Society of Allergy, Asthma, and Clinical Immunology, very, very actively involved in the adverse reactions of the vaccines during the COVID time. And he also heads the Allergy Immunology Unit of Fel de Mondo Medical Center. And I would like to now give the floor to him and ask him to moderate the session and take this webinar forward. So welcome, Professor Lobo.
Thank you, Professor Rupi Pawankar. It is indeed an honor and a pleasure to host and moderate these sessions. Now, there are a few reminders before we start. For the Chinese-speaking group in this virtual audience, to listen to the webinar in Chinese, please make sure to check the translation box option at the bottom of the right screen. It's roughly to the right of the raise hand and then record button. You just need to click it, select Chinese, but you need to mute your original option. Now, for housekeeping rules, this webinar will be recorded and will be uploaded to the APAACI TV, www.apaaci.org, and all other APAACI learning and online platforms. All the participants will be muted by the organizers upon entry. The question and answer features provide an opportunity for attendees to enter questions for the presenters, and at the end of the webinar, we will get the speakers to respond. Due to time restrictions, any questions left unanswered will be uploaded on the www.apaaci.org with the answers from each speaker. Now, let me introduce our first speaker. To talk on food allergies linked to eczema, she is a professor of the Allergy Immunology Unit, University of the Philippines, Philippine General Hospital, past president of the Philippine Society of Allergy and Immunology. He's a member of the European Academy of Allergy and Clinical Immunology. Ladies and gentlemen, please welcome to the virtual floor, Professor Maricia T. Recto.
Good evening, good afternoon, good morning, everyone. Thank you very much, Professor Lobo, Professor Pawangkar, and Professor Juyao for inviting me to speak regarding a topic that may be very relevant for everyone. So may I share my slides now? So I was tasked to discuss the relationships between two very important allergic conditions, especially in childhood. And these are food allergies and atopic dermatitis. We have seen in the past few decades that the patterns of allergic disease prevalence have indeed changed, wherein initially it was the respiratory allergies that became very much prevalent, but recently, starting around the early part of the 2000s, we see a surge in the prevalence of both atopic dermatitis and food allergies. In data, we have seen that the prevalence indeed of both conditions are increasing. In the USA, it has been found during this period that the prevalence of atopic dermatitis among children has increased dramatically to 70%, and that of reported food allergy by 50%. In our part of the world, in China, it has been found that there's an almost 50% increase in food allergy prevalence at around the same time period. And this continues to increase. Why is this happening? It is because of what we see in the phenomenon called epigenetics, wherein genetic factors are influenced by environment to lead to different changes in the way our genes are translated and transcribed and expressed. And this can lead to the emergence of many non-communicable diseases, including allergy. In this slide, we see here a list of common risk factors for the development of all types of allergic disease. And if you take note, highlighted in red over here is basically several factors that have something to do with our diet and the way we eat our food. So atopic dermatitis is often called the gateway to the atopic march. It is the most common chronic pruritic inflammatory skin disorder that affects almost 20% of children worldwide. Its etiology is complex and they present heterogeneously. There's a significant socioeconomic impact, and patients have increased risk of serious skin infections. But more importantly, this condition can predispose infants to the development of other atopic diseases like food allergy, respiratory allergies, and allergic keratoconjunctivitis. Now, food allergy, on the other hand, is an adverse food reaction that arises from a specific immune response that occurs reproducibly on exposure to a given food. Oftentimes, it is mistaken for atopic dermatitis, and atopic dermatitis sometimes is mistaken for a food allergy. But the prevalence of food allergies are really increasing. It has been shown that it's more common in children rather than adults, but there's been a dramatic increase in its prevalence, especially in food-related anaphylaxis in the past several years. So my discussion will be tackling several links and relationships of atopic dermatitis to food allergy, basically talking about the relationships in the atopic march, common risk factors of the two conditions, epidemiologic associations, and mechanisms that can explain their link. So we're all familiar with the phenomenon called the atopic march. This is the evolution of allergic conditions that in childhood starts most commonly with the skin or atopic dermatitis, followed very closely with food allergy. And as the child gets older, these conditions do not become as prevalent, but remember, they still persist until adulthood. And then now the respiratory allergies start emerging. So this is a transition from the skin and gut to the respiratory tract. We have also seen that early life atopic dermatitis and food allergy has been shown to be a major risk factor for any atopic disease. So you look at the risk factors for the atopic march. If you have patients with severe, persistent, early onset atopic dermatitis or early onset food allergies together with atopic dermatitis, they are more prone to developing the respiratory allergies later on. Now, another important fact to discuss is that both atopic dermatitis and food allergy have common risk factors throughout the child's life or the individual's life, from the prenatal period to birth all the way down to adulthood. And we could see here the different risk factors that occur from the environment. Aside from genetics, we have the kind of birth, the diet that they exhibit, even their hormonal changes can lead to development of atopic dermatitis in parallel. So that is something to consider. Now, epidemiologically, atopic dermatitis and its relationship to food allergy has been seen in some studies. One of the first studies to notice is the LEAP study. We all are aware of it, the Learning Early About Peanut Allergy study, which really looked at how early feeding with peanuts in children would lead to less risk of developing peanut allergy later in life. But what I'm concerned about is that in the group of patients that were included in this study, 321 of them had atopic dermatitis as infants, and 76% had at least one allergic disease, while 48% had multiple comorbidities. But more interestingly is that this group of patients, 40% had food allergy at the age of 5 years old. In the Philippines, a similar study was done looking at cross-sectional data of almost 1,299 children, and they found the prevalence of atopic dermatitis to be around 20%, and that around 12% of these children had some form of food allergy. But what's more interesting is the odds of developing atopic dermatitis was seen to be 3 times more among those with a personal history of food allergy compared to those without. So saying that the presence of food allergy is a major risk factor for developing atopic dermatitis rather than atopic dermatitis being a major risk factor in developing food allergy. So since then, other studies have come up, seeing that atopic dermatitis infants are 6 times more prone to developing food allergy compared to healthy peers. They are more likely to be sensitized to food antigens. But we have to remember that only 15 to 40% actually have a true clinical food allergy, because most of the patients in that kind of study just reported it based on their perception. So there are a lot of people who have perceived allergy, but really only a small amount have true clinical food allergy. Atopic dermatitis patients are 11 times and 6 times more likely to developing peanut and egg allergy by the age of 6 months and 12 months respectively. And at the age of 6 months are more likely to develop new onset food and inhalant sensitization by 1 and 2 years of age respectively. So this was all determined through data, epidemiologic data, looking at associations and relationships. And now we will look at the mechanisms by which there is a true link between the development of food allergy in atopic dermatitis. So it is known that food-specific IgE responses are already developed in patients with atopic dermatitis even in the first months of life. So it means that these children are can be sensitized already even before they ingest food. And this means that the sensitization does not come from ingestion, but rather through exposure through the inflamed skin. So this actually follows the theory of the effect of environmental factors on the epithelial barriers that can lead to the allergic inflammation. So in this very concrete diagram by Chesme Actis, you could see here that the exposome, which includes everything in the environment, including food, can have contact with the different epithelial surfaces of the skin, the airways, and even the gastrointestinal tract to activate both the innate and adaptive immune systems towards a Th2 type of inflammation that will lead to allergy. So the skin is the very obvious interface to the environment, although we have to remember that the respiratory tract and the gastrointestinal tract, although are not very visible, are still in interface to the environment. But the skin is often called the first line of defense between the body and environment. And this is where your gene-environment interactions begin, leading to disease emergence. So the skin, we always think of it as just the physical barrier, but the skin is actually a multi-tiered barrier involving the microbiome, its chemical barriers like the tight junctions, and even the immune cells, which function to retain moisture and repel allergens and microbes. But the stratum corneum is a very major part of this skin barrier. And the cutaneous skin barrier involves this very complicated scaffolding of different structural proteins that keep the lipid lamellae in order. And one of these very important proteins is a protein we know as filaggrin. So filaggrin is also known as filament aggregating protein, and its degradation products, which are what we call the natural moisturizing factors, have important skin functions for hydration, for maintaining that acidic pH that will prevent skin breakdown and be antimicrobial as well, for extracellular lipid formation, immune modulation, and photoprotection. But what's also important to know is the link between filaggrin deficiency and severity of allergic conditions. And not to mention in this slide that graphically shows that filaggrin deficiencies have a major impact on many kinds of allergic conditions, even the emergence of food allergy. So do we all have filaggrin deficiencies in atopic dermatitis? Most of the patients do have. Some are genetic and some occur, these deficiencies occur because of environmental degradation of filaggrin. So in a patient who has an intact skin barrier, you could see how well lined up all the cells are that prevents transepidermal water loss and prevents the entry of pathogens and allergens. But in atopic dermatitis, there is a breakdown of this structure, and you could see all the transepidermal water loss making the skin very dry and flaky. And you could see that the barrier is disrupted and open, and so you have ready entrance of allergens and infections that lead to inflammation. So the skin barrier impairment does not seem to just affect atopic dermatitis. The genes and environment that will lead to that defective and skin barrier may actually cause sensitization through the immune system, and this immune system, which can pass through the lymphatics, the immune cells, our Th2 cells that are formed or developed in the lymph nodes, can migrate even to the nasal tissues and bronchial tissues, and not to mention other parts, including the gastrointestinal tract, that can lead to possibly food allergy. So there are evidences that skin barrier impairment can cause allergy penetration and sensitization. It has been shown that when you have epicutaneous sensitization in presence of an adjuvant or with highly concentrated chronic exposure, this can cause food allergy, clinical food allergy, or airway allergic disease even without a disrupted barrier. So we sometimes don't need that barrier to cause sensitization through the skin. And it has been found that 32% of children who with atopic dermatitis who use oat-based creams, this is very common. No? Many people think oatmeal is a form of anti-inflammatory, but later on you would see that sensitization to oats will occur in patients with abraded skin. So we have to be careful with the kind of products that we apply on atopic dermatitis skin. And don't forget the dual allergen exposure hypothesis, which shows the route of antigen exposure can dictate whether allergy or tolerance to food protein develops. So we are all familiar with the fact that when we ingest food, oral exposure, we sometimes think that you will develop food allergy, but because of the gut-associated lymphoid tissues, you will actually develop more tolerance. T regulatory memory and Th1 memory are enhanced. And so it is actually protective towards allergies. So early ingestion of food is very important in trying to provide tolerance to the gastrointestinal tract and preventing food allergy. But cutaneous exposure has shown that you sensitize the person through the skin. There is no gut-associated lymphoid tissues, nothing to provide tolerance. And thus, instead of tolerance happening, you would now develop sensitization and allergy. This particular study is quite interesting, which showed a potential immunologic pathway that will link the skin barrier to the gut directly. And it has been found that the faulty skin barrier due to eczema can actually result in a form of intestinal mastocytosis characterized by interleukin-9 producing mast cells. And thus, this leads to an increased clinical reactivity to ingested food allergen. So it's not only due to the lack of tolerance, but also because of activation of a different pathway towards the development of sensitization. So what is the implication of diagnosing food allergy in atopic dermatitis patients? Oftentimes, people with atopic dermatitis who flare up think it is food-related. However, food allergy may present with immediate and or delayed onset types of reaction, and not all patients with atopic dermatitis have food allergy and even vice versa. But allergy testing should be done in the following patients: those with an immediate response after ingestion of a potentially causal food, and they have moderate to severe atopic dermatitis. Now, if these kinds of patients need evaluation, diagnosis requires a detailed skin allergy history, evidence of allergic sensitization either through skin prick tests or specific serum IgE testing, directed elimination diets, and food challenges. So we do not automatically put patients with atopic dermatitis on food or hypoallergenic diets or elimination diets, because this may be detrimental to their health. Now, sometimes elimination of allergic foods in the diet can improve atopic dermatitis control. And when we talk about allergenic foods, these are the top 8 food antigens, which are egg, milk, peanut, wheat, soy, fish, shellfish, and other nuts. But we have to be careful. We have to really document the presence of specific IgE, because putting them on these diets, especially for long periods of time, can lead to inadvertent malnutrition and even later on the development of severe IgE-mediated allergies like anaphylaxis on the first intake after elimination. So this just implies that skin barrier interventions in atopic dermatitis can lead to allergy prevention. So in primary prevention measures wherein we want to try to block sensitization, how can we do this in atopic dermatitis patient? But by strengthening the skin barrier by cleansers, moisturizers, and enhancing the skin microbiome. There's also secondary prevention measures in those who already have atopic dermatitis that we want to stop the progression to respiratory allergies by giving anti-inflammatory treatment or immunomodulation. So how can we address the skin barrier perturbations to prevent atopic dermatitis and subsequently food allergies? We can actually remember this, that the atopic dermatitis barrier is leaky, and we can do emollients to provide skin barrier control and blocking the inflammatory cascade in a preventive manner. Now, there are some studies that have shown that early emollient use in infants can prevent the onset of atopic dermatitis and food sensitization. In these 3 landmark studies, it has been found that in high-risk patients, these are those with a family history of atopic dermatitis, and they were given emollients at birth, no? You could see that there are those that show that it did not prevent allergy sensitization, but a lot of them were found to be preventive against the onset of atopic dermatitis, and eventually we would surmise that even food allergy sensitization may possibly be prevented. So it is unclear whether long-lasting prevention of atopic dermatitis is achieved or whether the expression of atopic dermatitis is delayed or masked by regular applications of emollients to neonatal skin. Preventive effects of emollients can be ingredient dependent. So not all, that's why the studies were heterogeneous, is because the different types of emollients may not have produced the similar results that we would expect. Emollient-only interventions have been shown to decrease occurrence of atopic dermatitis only by 50%, which means that further prevention can be done by the concurrent early proactive use of anti-inflammatory therapy to decrease non-lesional AD changes and also to control the skin barrier and make it intact. So this is what we call proactive therapy, wherein versus reactive therapy, wherein we try to give our anti-inflammatory agents only during flares. We do not take care in this type of treatment to subclinical inflammation. But if we do early induction of remission by doing proactive treatment with anti-inflammatory agents, then you could see with time, eventually the subclinical inflammation is controlled and we would have better outcomes for our patients with atopic dermatitis and possibly food allergy. So my last few slides will discuss some exciting studies on how we can improve eczema and decrease the later development of food allergies. So this study by Miyagi et al., which was recently published in the APAACI in Practice, showed that in eczematous infants who were given topical steroid treatment early in the course of their eczema versus those that were given it much later on in the course of their condition, were seen the intervention was whether they found differences in initiating topical steroid intervention before the onset of symptoms in what we call proactive therapy and the development of food allergy. So those who were given early versus those that were given late proactive therapy. The course was basically looking at the early treatment group that it was given within 4 months of eczema symptoms, and the delayed treatment group after 4 months of eczema symptoms. So these were the comparators. And the outcome found was that 25% of the early treatment group infants developed food allergy at 22 to 24 months versus 46.3% in the delayed treatment group. And this difference was statistically significant. So if you treat early, 25%, almost half, were prevented against the development of food allergy by 2 years of age. And this is the preliminary study to an ongoing study called the APAACI, Prevention of Allergy via Cutaneous Intervention. Is a randomized trial that will measure the effects of aggressive proactive treatment of very young infants with atopic dermatitis versus standard reactive treatment for preventing challenge-proven IgE-mediated egg allergy at 28 weeks of age. So I hope with this, I have given you some food for thought by looking at this integrated model for nutritional intervention and skincare for food allergy prevention. This actually summarizes everything that if we take care of our skin, we do preventive measures, food allergy can actually be prevented. And this was in guidelines that show that aside from the complementary feeding, early complementary feeding, breastfeeding, the use of supplements like probiotics, prebiotics, and LC-PUFAs, we have to take care of the skin barrier, maintain it in the early life of the child to prevent food allergy, because there really seems to be a strong link between these two conditions. So thank you very much for your kind attention.
Thank you, Professor Marisha Recto, for that excellent delivery of that lecture. I'm sure it has stimulated the intellectual mind of our audience. That's why they're now trying to put in their question. Now, let me introduce our next speaker, who will talk on real-world data in asthma and allergic rhinitis, how to outline therapeutic approaches. He's one of the main authors of GINA and ARIA. He's a guru in allergy. He's a professor of respiratory medicine, Humanitas University, head personalized medicine, asthma and allergy clinic, Humanitas Research Hospital, Milano, Italy, president, the Respiratory Effectiveness Group, editor-in-chief, Current Opinion, Allergy and Clinical Immunology. Professors, friends, please all welcome to the virtual floor, Professor Giorgio Walter Canonica. Professor, you're on.
Thank you very much for this kind introduction. And of course, thank you for the invitation, actually to talk about a hot topic. Why a hot topic? Because actually nowadays, the real world data are becoming more and more important, and I will try to, let's say, to convince you that this is the case. First of all, of course, my disclosure of interests, and then let me talk about the real world evidences. Well, let's say that since the beginning of the history in terms of research, actually we were considered just the real world evidences, but then in the 40s of the last century, I mean, the randomized control trial and mainly the double-blind placebo control trial, they became the model for registration of drugs. Just in the beginning of this century, and more attention has been paid to the real-world evidences. Why this? Well, this is the kind of patients that we are selecting and treating during the randomized control trials, or better, the double-blind placebo control trials. And this is what we have to treat every day. So there are a lot of differences since the outcome. One is called efficacy and the other one is called effectiveness. To make a more easy way to see, this is the kind of patient, the perfect patient, that is selected for the randomized control trials. Whereas you might be lacking clinical practice, but you can find, for instance, a patient like this. So totally different compared to the ones selected for the randomized control trials. Let me give you some examples. For instance, you know that actually less than 1.5% of the real asthma population is enrolled in clinical trials. Why? Because selecting for not having comorbidity, for not, smoking, for having a certain FEV1 and so, and even more impacting. It was calculated and published that less than 5% of the asthmatics currently treated in Italy with omalizumab could have been enrolled in the registration trial for this same drug. Now this is something that was published a couple of years ago. And this is a retrospective evaluation of all the registration trials for the biologics. Look, the age, totally different compared to the age of the asthmatics in the US, for instance. But even worse, look at the BMI. That is totally different. Keep it in mind because this is going to be very important in a while. We know nowadays that obesity alters the pathology and also the treatment response in inflammatory diseases. I think that this is a great demonstration. Look at the different diet, how it could determine a different kind of inflammation. And this is the diet, but look down, how the obese, in this case, animals, they have much more inflammation. And let me say that Chesney-Actis and this group, they demonstrated that innate lymphoid cells in obese asthma patients are activated. And you can look that they are activated in the peripheral blood, and mainly ILC and ILC3 in particular. So we are talking about patients with a different profile compared to the normal ones. And this has to be in mind. Finally, let me talk about the race of the patients. As you can see, this is the number of the Afro-Americans in the American asthmatic population. Look, no African-American practically recruited in the registration trials. There is a need for an evaluation of ethnic diversity, but keeping in mind that the vast majority in the States of the asthmatic population is Puerto Ricans or Afro-Americans, more than 50%. I mean, the whites are less than 10%. Keep it in mind. Asthma mortality is 4 times more in Puerto Ricans and in Afro-Americans. Well, the registration trial that was done for children it was recruiting, or mainly, more than 90%, white people, white children. So being this the case, I mean, there are limits to generalized use of these tools. And more extensively, we are using the biomarkers. But do we know that there are differences in terms of race, of ethnic group, about, for instance, eosinophils? And this is demonstrated. So we have to break the skin color barriers as far as asthma medication is concerned. Unfortunately, this is not the case just for asthma. Look at the head and neck cancer trials in the last decades. And in the last decades, only 57% of the study, they indicated the race of the patients that were recruited in the trials. So it's really, and look, and the vast majority, almost the totality, was white. So we have really the underrepresentation of this population that may mask, what is really the existing racial disparities and also the response. And that's the reason why, less than 1 year ago, FDA took the important step to increase the racial and ethnic diversity in clinical trials. How to deal between the randomized and the real-life research? Well, they have to be complementary. And I take this suggestion by Holger Schunemann, one of the best methodologists in the world, who published 10 years ago that a non-randomized study can be source of complementary, sequential, or replacement evidence for randomized control trial in systemic reviews on the effects of intervention. I mean, this can be in a way or another something that we can apply also to guidelines, for instance, and this is something that will be discussed in a while. We, as REG, Respiratory Effectiveness Group, and the WOW, World Allergy Organization, we published a manifesto concerning the real-life research, and you can see here actually the different type of research that can be done. And recently, the effectiveness of some drugs led to the registration of those drugs too. So we proposed, as far as allergy immunotherapy is concerned, a new hierarchy of the real-world evidences, starting from the expert evidence or experience through the retrospective, going to the prospective database and the registry real-world evidence. And we focused on the registry as a great source of important and credible data. And that's the reason why we concluded with a call to action to establish more allergen immunotherapy registries and this. With David Price, actually, we revised also what is the role of real-world evidence from registry as far as biologics in severe asthma. And these are the data about the real-world evidence studies, retrospective, prospective, and with the registry. But as you can see, actually, this is something that can be revised, I would say, every week, because we have so many publications in this field. What we proposed is that if you consider effectiveness and efficacy, well, definitely the randomized control trials are the registration trials, I mean, are the best as far as efficacy is concerned. But also pragmatic randomized trial and registry and prospective observational trials can be, of course, quite important as far as effectiveness is concerned, but also they can provide some evidence of efficacy. So the promotion is to have a registry that will enable to the investigation of severe asthmatic phenotypes, and also the effectiveness of various treatment and the economic impact of them. As far as the severe asthma registry, I will try to shortly showing you how important it is. We learned, for instance, from our own registry in Italy, SANI, that oral corticosteroids were highly used, and the comorbidities were something that surprised us. And as far as oral corticosteroids, more than 64% of the patients were on more than 10 milligrams of prednisone a day. And then, I mean, also the other registry, they investigated it, and they discovered that was the same. Look at the UK asthma registry with the same percentage of person and with the same dosage of steroid. And this is a cost. Why? Because the side effects were calculated to be of high impact in the population of severe asthmatics in Italy treated with oral corticosteroids. And finally, one side effect that is not usually considered but is impacting is the increased mortality in a dose-dependent fashion of patients treated with oral corticosteroids. We know that actually the biologics are able to have a sparing effect on the use of systemic steroids. And that's the reason why, as Sunny, as at the end of the story, we underline that the use of biologics, I mean, they have as privileged outcome the sparing oral corticosteroids. And very, very pleased that actually in the guidelines, they accepted the concept that oral corticosteroids are the last resort in the treatment of asthma. And also the charter of patients carrying severe asthma actually focused on 6 different points, all of them very, very important. I mean, but in the 5th one, they say that the patients deserves not to be reliant on oral corticosteroids. And this is very important. And in addition, I mean, they should be allowed to consistently have the chance to be treated properly in any place of the world. Briefly about the comorbidities. As I mentioned, we, let's say, find out that more than 42% of the patients with severe asthma, they have nasal polyposis. And these patients, they have more exacerbation per year, and they use the oral corticosteroids twice the days per year. So they are more actually severe than the ones just having severe asthma. And finally, 1/4 of them, they have bronchiectasis. I mean, and once again, they have more use of oral corticosteroids and more severe symptoms. So to make a long story short, so this real-world evidence approach teaches us that nowadays you cannot diagnose properly a severe asthma without a multidisciplinary team approach. And that I mean the ENT and the imaging people for bronchiectasis. Finally, this kind of approach teaches us that as far as LAMA is concerned, for instance, I mean, just 36% of patients with severe asthma, they are using LAMA. And 40% of them, they are not using the only one that is currently approved for asthma, which is the tiotropium respimat. International registries, SHARP and ISAR, are very, very important. I mean, the mission statement of ISAR was involving several different registries. We are now having more than 2,000 patients in our Italian one. But I wish to say how important this kind of study can be. For instance, do you remember what I was mentioning about the registration trial for biologics and obesity? Look, the cluster analysis demonstrated that 61% of patients are obese females. Now, what about the eosinophilic and the non-eosinophilic asthma? Well, we demonstrated that, for instance, 90% of the patients in Italy, they have eosinophilic asthma, which if you look at the previous cohorts, it's surprising. Why? Because having eosinophilic asthma in the ISAR is quite high, but this was not the case in the EuBioPred cluster. And even worse, if you look at the non-eosinophilic asthma that was described, 30% of the patients currently nowadays is 1.6 in the ISAR. So I think that the data are quite impacting. So it's time for a change. Time for a change. And I wish to conclude with a key message that is really a call to action, to establish more and more disease registries, to properly collect real-world big data. And then you can use machine learning or artificial intelligence, to deal and to drive the clinical practice, of course, combining this kind of data with the one of the registration trial. With this, I thank my team in Humanitas University, and of course, you all for your kind attention.
Thank you, Professor Walter Canonica, for that excellent talk. Our next speaker will present case studies on food allergy, allergic rhinitis, and asthma. He is an assistant professor, Division of Allergy, Clinical Immunology, Department of Medicine, Siriaj Hospital, Mahidol University, Thailand, a junior member of the APAACI. Ladies and gentlemen, doctors, please welcome Professor Dr. Mongporn Sopornranatapan. Professor, the floor is now open for you to deliver your talk.
Okay, thank you very much, Professor Romel. So let me share my slide here. Okay. Good evening, good afternoon, and good morning to every colleagues from China and also other regions. The last session, I'm going to talk about the case study with the link between the food allergy and the allergic airway diseases. And here is my disclosure. And I will go through all of the topics listed here. Begin with the case scenario. Here, I have a chance to take care of a 18-year-old woman with the moderate to severe allergic rhinitis since the age of 6, asthma since the age of 7, shellfish anaphylaxis since the age of 13. She was taken care from the pediatric allergist. And finally, at the age of 18, she was then transferred to the adult allergist, which is me, with a new complaint that she had 3 times of anaphylaxis within these years. And at that time, she did not recognize what is the trigger in those episodes. She said, it is a regular meal that I have had. But one thing that she could recall is that those 3 reactions is associated with the exercise and exertion something. So at the first time we met her, we suggest her to record the food diary, carrying the adrenaline auto-injector, and then got the appointment. And here is the diary we got from her. On February 2016, in the morning, 8 p.m., she ate soybean milk, then playing the hula hoop. And 15 minutes later, she finally got a rash, just tiny and near syncope, and went to the ED visit due to her anaphylaxis. And on April 2016, she ate fried tilapia and go jogging, and then anaphylaxis happened again along with the wheezing. And on the next month, she had 2 slices of bread, then playing hula hoop again, very interesting. And then she developed the 3rd time anaphylaxis. So if you look into the list of the food here, they could not directly group together. But if I would say that in the Asian cuisine, they had such a complicated issue, because if we don't look closer into it, we might miss some of the shared and hidden ingredient in the list. So in the detailed history, one would suspect that there might be some kind of wheat or gluten ingredient. If we ask about the detail of fried tilapia, they use the newly opened cooking flour. So then we could plan for the further investigation to find the cause of the anaphylaxis in this case. Also, she gave me the additional history that she could eat gluten-containing food in many occasions, and she was generally well if she did not go for exercise or hula hoop again. In our case, we perform both skin prick tests to the food panels and the specific IgE to the food allergens. So let's see the result. She had a positive skin test to shrimp and crab, and this could explain the previous shellfish allergy which happened earlier. But here we had the negative skin test to wheat, soy, and peanut, and also negative IgE to wheat. It is important to know that the IgE to wheat, which means that the crude wheat extract used in the immunocap, the yield might not be high enough to detect some component in it, especially in the adult population. So we still look for the component, the omega-5 gliadin IgE, and the results show a high level of 15.2 kilo unit of allergen per liter. So we diagnosed her as wheat allergy, and because she could eat gluten at rest without exertion, without reaction, she was well. So the wheat-dependent exercise immunoanaphylaxis or VDIA phenotype is now suspected in this case. So at this point, what we're going to do we have to A, oral food challenge or OFC, or B, we perform OFC with cofactors, or C, no further tests required. VDIA could be diagnosed at this moment. So let's see the recommendation. In the 2022 molecular allergology from the APAACI, in general wheat phenotype, as you see, when IgE to wheat was negative, then we should perform the skin prick test to wheat and also gliadin first. And if you want to confirm, the OFC could be done in the next step. But it is important to know that if we don't have the gliadin extract for the skin test, before going to OFC, especially in case with severe reaction, another option is to test for the gliadin IgE. And here is depending on the history, if there are some objective systemic symptoms after the undisputable exposure, this point, it might be enough for wheat allergy diagnosis. So let's go back to the case. Do you know what is the phenotype in our case? When we see the adult onset wheat allergy, which the reaction occur after the combination of eating wheat and combination with exercise, our case is compatible with the phenotype B, which the omega-5 gliadin is the most important. And then let's see what they recommend about the OFC in this clinical pattern. In clinical pattern B, the history and the IgE testing are enough for the diagnosis. Some center might use the combination of wheat challenge plus a cofactor together to yield a higher positivity rate. And you might consider to perform the OFC with cofactor in the uncertain case, just like the idiopathic anaphylaxis, but we have to carefully monitor during the procedure. So I would like to talk about the cofactor in more detail. There are many studies measure the effect of the cofactor here. The cofactor increase the probability of the positive challenge by interacting with the food threshold. And some centers, as you can see here, use a combination of the aspirin and exercise together. And the latter study from the Professor Brockcrohn team show that sometimes this phenotype could be positive at rest when you perform OFC with a high amount of the purified gluten. Actually, in the last several years ago in our center, we also performed the food challenge with the cofactor systematically. We exclude the aspirin intolerance on the admission using the grade 5 aspirin. Then we performed the exercise challenge on the first day, followed by the wheat challenge on the second day, and the combining between the wheat and without cofactor on the third day. And we found that the protocol could separate between the typical wheat allergic patients from the VDIA phenotype, and the prominent phenotype in our adult cohort in Thailand was VDIA. We do know that the one patient still have the negative challenge, and one patient in our study experienced a severe reaction on the third day, resulting in the IV adrenaline administration. So at the moment, we do not perform the protocol routinely, except in cases who are eager to do that. Okay, but what we did in the case, actually, in this case, the diagnosis of the omega-5 gliadin allergy could be met at this point. But what we did to the case is that we performed the OFC to wheat at rest, and it was negative. So this could confirm her threshold at rest. And we said that, oh, okay, it is high likely to be a VDA phenotype. And I would like to emphasize that this is optional, and we should carefully select and educate the patient before doing that, because this might mislead them to believe that they are not allergic to wheat. So the diagnosis of VDA or omega-5 gliadin syndrome was made. And very interesting data from Hong Kong from Professor Lee show that the omega-5 gliadin syndrome could be a cause in patients previously diagnosed with the idiopathic anaphylaxis. So it is important to work up the omega-5 gliadin in such cases. So for the management, we know that the general management of food allergy includes to avoiding the food they are allergic to, carrying the adrenaline, having the action plan and advanced care in some cases, and to treat all the comorbidities, which is very important, just like Professor Marissa said before. But what about the VDA phenotype? What do you think? Should we recommend them to avoid eating gluten and wheat? Absolutely. Or able to eat wheat and gluten, but avoid exercise during the next consecutive 4 to 6 hours? Or we avoid wheat, gluten, and also avoid exercise. This is quite tough. So let's see what the other allergies did. Here is the result from the multi-center data from the UK. The advice given to the patient are summarized here. The most common advice is to avoid wheat with the exercise. This means when you eat wheat, you should avoid exercise. But if you can exercise with prior, but you can exercise without the prior wheat intake. And the other option are the gluten-free, suggest to have wheat-free, reduce wheat and exercise. But is it work in real life after the advice? So please look at the proportion of no reaction after the advice. You can see that wheat and exercise avoidance here or to advise the gluten-free achieve the high percentage of no reaction. However, this is the observational study. You can control all the confounding factors, and some group had very small number of patients in the row here. So this could be a preliminary suggest a good advice when you select a case by case. Another point is that you might see that the failure observed in the wheat-free here in about 70% here, while advising the gluten-free achieve the failure rate around the 30%. So what is the difference between the wheat-free and gluten-free here? We think this slide from the Professor Panchama, and here is the fact from the US FDA that the gluten-free is defined as the food product which contains gluten less than 20 ppm, but the gluten-containing grain also include in other grains such as wheat, barley, rye, or spelt. But in wheat-free, this means that free from any component of wheat. However, but it still contains other gluten-containing grains because there are gluten from barley, rye, or some other kind of cereal. So this is the difference. The good way to do is that we should advise the patient to avoid both wheat and gluten-free in patients with highly sensitive to wheat. So okay, we now move to the 6 years later. She was now a nurse, 24 years old, the same person. She had now complained of having the hand eczema, contact urticaria to latex growth. And she also had the swollen lips and tongue after eating banana and kiwi fruit. and had anaphylaxis after eating banana in some occasion. So this is compatible with some syndrome we might know. So we have to confirm it before to investigate by the prick-to-prick test, which were done and positive to both banana and kiwi, and also positive to banana-specific IgE. And this is compatible with the latex fruit association, which is the linkage between the latex with immediate type with hypersensitivity to the related fruits. And if we look back to the previous diagnosis, in summary, in this patient, she had 3 food allergies, which are shellfish, wheat, and also plant food allergy too. And all of which had anaphylactic reaction in her most severe reaction. So I'm going to point out about the food allergy in adult. And I think many allergists are now aware of its increasing in the adult. And our team have recently published the review in the article in the journal APAACI, which might be useful for everyone who take care of the adult patient who had food allergies. As you can see, the global prevalence of the food allergy in adults was reported in many regions. And it's very surprising that adult prevalence is higher than we expected. And there are some clinical phenotypes which are predominantly found in the adults. And also they have many routes of sensitization leading to the clinical allergy. And also the interaction between various types of cofactor and food allergen, which are very important in the adult patient. And if we look to the study from the adult food allergy data from the US, using a model to predict the composite FAME score, you will see that the adult patients who had both child onset and adult onset food allergy most suffer from the psychological burden and quality of life than the childhood onset only and the adult onset only food allergic patients. And also you can see that in the both childhood onset and adult onset allergic patient had the highest levels of all reported comorbidities compared to the other 2 groups. And our patients in the care scenario seems like to fit in within the frame because she had nearly all of the listed comorbidity shown here. So in summary, both childhood and the adult onset food allergy had the highest severity, comorbidities, healthcare utilization, and also highest level report burden on the quality of life. And I think this finding is similar to the patient in our center. So in conclusion to the overall, you will see that both childhood and adult onset food allergic patients might have the highest severity, number of atopic comorbidity, and worse quality of life. There might be some possible linkage between the food allergy and allergic respiratory diseases, and also in eczema or atopic dermatitis, just like Professor Marisa Rector said. Future intervention to prevent or treatment are encouraged, especially in adult patients. And it is very essential to focus that the comorbidity assessment and the treatment should be included as a part of routine food allergy management. So thank you very much.
Thank you very much, professors. Now, can we call on the 3 speakers in the virtual floor so we can start the question and answer portion? There are a lot of questions in the box. Can we start off with, I think this is addressed to Professor Marisa Recto. What adjuvants are implicated to increase risk of food allergy in atopic dermatitis patients?
Well, when we talk about an adjuvant, it is a substance that increases the immunogenicity or the allergenicity of a food protein. And in animal studies, it has been found that certain toxins or certain infectious agents can actually act as adjuvants, and also certain chemical factors or chemical substances that are found together, let's say with emollients, that can actually cause increased reactivity of the protein antigen. So in one study, it has been found that Staphylococcus toxin, which is often seen in patients with atopic dermatitis, because staph infections are very common in atopic dermatitis, can increase sensitization through the skin because it causes also more damage. And also certain products like alum or even nickel that may be found, or metals that are found in certain products that are applied on the skin together with inflammation can trigger immunogenicity.
Thank you, Professor. The next question, I think, is more of a comment. I would just like to read it. I'm using serum IgE for food allergy test, but it hardly comes out positive. I don't know what the question there is, but
Maybe I think I mentioned that during the lecture, that when we should do serum IgE testing or skin testing. And we just have to realize that not all triggers of atopic dermatitis are food antigens. So sometimes when we do food testing, you will really not yield anything because the trigger is not always triggered by an allergen. It can be triggered by chemicals, sweating, it can be triggered by infections, the flare-ups. So we should not be surprised that sometimes, or most of the time, food antigens do not cause sensitization in patients with atopic dermatitis. There's really a certain population only of atopic dermatitis patients that have real food allergy.
Marisha, I have one clarification. You mentioned something about food allergy being part of preceding atopic dermatitis, while what we know is that atopic dermatitis precedes food allergy. Is that, did I hear it right?
No, actually, what I think that was the Philippine study,
Yeah.
wherein they found out that patients with atopic dermatitis, a certain portion of them had food allergy, but not all patients with atopic dermatitis had food allergy. So presence of food sensitization or allergy is not always found in atopic dermatitis. I think that's the most important thing to remember.
Okay, thank you. Thank you for that clarification. What other lectures? This is another question to you. Many emollients available for AD contain oatmeal, claiming it to be anti-inflammatory and good for eczematous skin. So as per the study highlighted in the presentation, should we use oatmeal-based emollients on AD babies?
You know, Romel, 20 years ago, when I started my practice, oatmeal-based preparations were very popular. In fact, there were no other options that we had too much for atopic dermatitis. It has been found that oatmeal preparations can soothe itching. However, because of the phenomenon of epicutaneous sensitization, then we have now many patients. I have personally seen this in my patients who I started on emollients that have oatmeal, developing oatmeal allergies. So we have to be careful, especially those that are high risk with inflamed skin and they have the genetics, they may eventually develop oatmeal allergy. That's why in atopic dermatitis patients, I do not recommend applying oatmeal-based or even cereal-based products on the skin.
Actually, when I started, there was even micronized oatmeal.
Yes.
Which some patients will complain of stinging.
It's better to eat the protein or eat the oatmeal rather than to put it on the skin.
Professor Walter, would you like to
Yeah,
add?
I am.
Yes, Professor. Regarding the oatmeal-based eczemas moisturizer content?
Well, I would add just a little point. I think that nowadays it's always important to properly evaluate, and this is true also for a rare disease such as eosinophilic esophagitis that is becoming more and more important. And I do suggest the use of the molecular diagnosis, because the molecular component diagnosis is able, for instance, to reveal the cross-reaction of some foods with in patients sensitized to some inhalants. I mean, I wouldn't say that this is so frequent, but think about that, for instance, in esophagitis, 70% of the patients, they have sensitizations to some foods. So I'm convinced that this is something that I'm currently already saying, is that we cannot go ahead just using the skin tests. Sorry about that, but this is something that is an allergist of 19th century, not is not anymore the allergist of the future. The allergist of the future should have different tools as any other specialist.
Actually, Professor, I do agree with you, because there are some patients here in the Philippines that I could not even track what could be the possible cause of their food allergies when we do the skin test or by doing detailed history. Most of it are negative, and then I would just order a molecular diagnostics and we'll wait for it to come back, only to be passed from the 295 allergens that we tested. It's only one, omega-5 gliadin. And then, talking about omega-5 gliadin, Professor Moncorn, how's your experience with your molecular diagnostic test? Do you still, for those who have suffered anaphylaxis, do you not fear them having anaphylaxis when you do your skin test?
Yes, first in the patient with anaphylaxis, if the history was very convincing with the phenotype of VIDIA or the adult onset wheat, we have skin test to put wheat extract and also the in-house preparation of the gliadin extract, which could screen in most patients and turn the high positivity rate. But also I performed the immunocap to the omega-5 gliadin in such case. I think the result is very impressive. More than 90% has positive, and which relate to the clinical history.
Oh, that's,
Yeah.
thank you.
Can I ask Romero?
Yes, Professor Ruby, what
Yeah,
is the
no,
question?
my question or comment was to Professor Recto's Marissa's, the findings in Philippines of people with atopic dermatitis having not having food allergies. It could also be the age group, because sometimes some of them have already outgrown their food allergies and they are coming with atopic dermatitis at a later stage. They might have had eczema as kids, and when they come to the tertiary center with more severe atopic dermatitis, by that time they could have outgrown their food allergies also, especially if it's like cows, milk, and egg. So is that, I mean, do we have any data on that, or that's a possibility that you would keep in mind?
Yes, I think this study was done in older children. Okay, so between 2 to 4. So there's really a chance that these children have already developed tolerance to their food antigens, but they still have their atopic dermatitis.
Yeah. So that means it's possible that they did have food allergies.
Yes.
But it's not that they were negative. So like you rightly said, all atopic dermatitis doesn't have food allergies, but many people with food allergies do have a background of atopic dermatitis. So
yes, that's right.
And I have one more question. May I ask Professor Momongkong?
Yes, Professor, go ahead.
Yeah, I mean, one of the things I noticed you were doing, which I found very interesting, is that you do the exercise test before you do the challenge with the wheat and then the wheat plus aspirin, correct?
Yes.
Yeah, because
Yes,
there's
Professor.
also exercise-induced anaphylaxis is also a possibility. And very often we find in the age group of, say, teenagers and above, when they have like food-dependent exercise-induced anaphylaxis, whether it's to wheat or to soy or to crustaceans, that their skin test is negative. And so when we take them for a challenge, we don't do an exercise test, but we start with just the food. We do the oral challenge, and then if it's negative, then we do it with the combination with aspirin. But I think your way of doing this is more reasonable. Very often parents don't like to stay 3 days in the hospital. That's the thing.
Yes,
Do you
that's
find
correct.
that as a challenge? Do you find that as a challenge?
Yes, we performed in most patients I took care of it, the adolescent to adult, which is quite severe. But it was several years ago that we performed the 3 days challenge protocol. But it turned that it had high yield, it's okay, but some patient developed severe reaction at the 3rd day. And we found that if we link to the component of the omega-5 gliadin, the yield of the diagnosis is very high. So in the 3 to 4 years ago, we did not perform the 3 days challenge anymore, except in case with the uncertain history of wheat ingestion or the idiopathic anaphylaxis, we might perform that.
May I ask one more question, Professor Lobo?
Yes, ma'am, you can go ahead.
This one is to Professor Walter, Professor Canonica. I think the role of the real world evidence is becoming more and more important. Because, as you rightly said, clinical trials are under very restricted circumstances. So for a region like Asia that is so culturally diverse, resources are diverse, food habits are diverse, I mean, how do we actually, we would love to follow that kind of a system where we could have a registry and where we could really have some consensus on real world evidence. So if you have any advice, we'd be very grateful.
Well, as far as the consensus, I think that it's important, Ruby. I think that first of all, we have to disseminate a different knowledge compared to the past, and people should become aware that there is, a reality that is important to evaluate. Since I believe that there are no resources, sufficient resources, to perform randomized double-blind placebo-controlled trials for all the questions that actually we are facing in clinical practice. I think that we have to find out a surrogate, a credible surrogate. And that's the reason why we have to create and to agree, to have a consensus on what are the procedures in real life, as far as the real world evidence is concerned, that are credible. And in this sense, I'm personally convinced nowadays that registry are a very useful and fruitful tool to help us.
Thank you very much. We will follow you.
Thank you, Professor. Here's a question again for Professor Canonica. It mentions here that can you use inhaled nasal steroids for allergic rhinitis and at the same time inhaled preventer simultaneously for asthma, Professor?
Well, this is a good question. If the question is, do we have data about the safety of inhaled nasal and inhaled bronchial steroids? We don't have so many. So it depends, of course, of the clinical situation. But I would say that in certain circumstances, in clinical practice, we can combine them. But we should start thinking about monitoring also the safety. Unfortunately, I have to say that this was not the case in the past.
There are a lot of questions in the question and answer box, but I think any of you can answer this one important question. Is there a role of the microbiome or probiotics in allergies? Maybe can I have your point of view in this question, Professor? Microbiome in allergies or probiotics in allergy.
If the question is to me, I have an answer. Yes.
Yes, Professor. Can you enlighten us about your point of view in microbiome probiotics in allergies, its role?
Well, I think that nowadays we know that I mean in allergy, and not just in allergy. I mean there is a reevaluation. For instance, let me just provoke you all. Think about the bacterial lysates that were not considered for a long time as a real treatment, whereas nowadays they are becoming more and more impacting, you know, mainly in allergy, but, you know, in COVID too, having been demonstrated to downregulate the AC2, so the receptors of the SARS-CoV-2. So I think that the more and more we are investigating properly, and the more and more we have to enlarge our view.
And if I could add something to what Walter said.
Yes, ma'am. Yes, ma'am.
Yeah, and this is Walter is also part of it because we did this GLADP paper many years back, led by Professor Fiocchi. And that's looking at actually basically the preventative aspects on allergy. And the only data we got was for probiotics, because neither prebiotics nor the vitamin D at that stage showed any evidence. Probiotics showed some marginal evidence in preventing eczema in a proportion of patients. But again, and I'm sure Walter will agree with this, is that the most important thing is strain specific. So each strain has to be separately studied in order to understand whether that particular probiotic is effective or not, whether it's in prevention or in treatment. Walter?
I fully agree.
Okay. Professor Moncorn, do you have something to add in that regarding the role of probiotics in allergies?
Actually, in my experience was not used probiotic in routine practice right now. We have only few experience about that.
Okay, thank you. How about you, Professor Marie Sharek?
Well, theoretically, and they've seen in some studies that there is a role of the microbiome in modulating allergies or enhancing allergies. And so probiotics naturally will be a very interesting immunomodulator. But as Professor Ruby has mentioned, the studies are quite heterogeneous. And so we really can't make any conclusions now because of the study designs. But for me, I look at it as a glass half full rather than empty, meaning that the absence of data doesn't mean there's no data. Okay?
Yeah, I agree with
we
you.
just need to have more studies, more definite studies for this.
Yeah, right now I'm trying to read up on microbiome in asthma, in allergic rhinitis, atopic dermatitis. There's a lot of things that you read, and then you just have to take it with a grain of salt. Now, there are other questions that we will not be able to answer because of time limitation, but let me assure you that it will be uploaded. Your answers will be uploaded to the www.apaaci.org website with the answers from each speaker. I think it's already 7:30, and then that's about the only time left for the question and answer. We have reached the time limit.
So may I take this opportunity to thank Professor Lobo for moderating the session so beautifully. I thank Professor Marisa Recto, Professor Walter Canonica, and Professor Moncon for the excellent talks that were so informative, educative, and stimulating to so many, so many questions. It's really interesting to see the extent of questions. So we look forward to having more of this, and we thank you for your time and expertise. And we look forward to having you more and more in our APAACI initiatives, both on behalf of Professor Jia Wang, myself, and the whole APAACI board. We thank you very much from the bottom of our hearts. And then finally, I would like to invite you once again to the APAACI Congress, APAACI 2023. This will be on from October 23 to 26 in Singapore. This is being jointly organized together with the Allergy and Clinical Immunology Society of Singapore. And please note that we have an exciting program for you. And we had the Congress in 2010 in Singapore, and this will be a beautiful venue with lots of fun. We will also have lots of other initiatives together with the scientific stimulating and networking programs and junior member programs. So welcome to APAACI 2023. And I also would like to announce APAACI Allergy Week that we will be announcing in our newsletter. Thank you all, and bye-bye.
Ciao.
Ciao. Let's all have a picture
Bye-bye.
together.
Thank you.
One picture together. Okay.
Oh, okay.
Bye.
Just take the picture.
Okay.
Thank you. Thank you.
Bye.
Bye-bye.
Thank you.
Bye-bye.
Thank you.
Glad to see you.
Bye. Thank you so
Yes.
much. Thank you very much. It was
Thank
excellent.
you.
Brilliant session. Brilliant moderation. Brilliant session. Thank you so much.
Thank you.
Bye.